what happens is that the foot turns in, it's usually a bit smaller than normal, and then they'll tend to walk on their ankles because it turns in so much. There's another picture here. So you can see, I mean, it's curving in so much that if they put their weight on it, they're going to be walking on their malleolus.
Did you see footage of that woman in China whose feet are on backwards?
What?
Yeah. She just lived with it. She's like, I'm okay.
I mean, I think it's in Japan, I think, where women will tie their feet to, it's supposed to be, is it China? So like a smaller foot is supposed to be more aesthetic. Sign this roll sheet signing thing. Okay. And then also, if you haven't already signed this photo release thing for the YouTube stuff.
Get out of here. Oh, sorry. That's funny.
Well, because, you know, I've been putting stuff on YouTube, and like we did last week, we had some people that did their extra credit stuff, and they put it on YouTube, and I want to make sure everybody has it signed. If you don't want to show up in there, I guess I could put a little black thing over your face or something like that. It'll pixelate you out. So there's two things. There's a sign-in sheet and then there's that, if you didn't already sign.
Where you going?
Okay, so then now we're going to get into history. And then it's the same types of things. You always ask the same types of questions. How did it happen? Has it happened before? Have you had any treatment before? Mechanism of injury. Again, if you're talking about ankle injuries, people that sprain their ankles, a lot of times they'll say, oh yeah, I've sprained my ankle dozens of times. So again, you always want to do a good history. Because, I mean, like I've talked about before, you know, so you start out with a bullseye and you're starting out in the big picture. The more you can do the history and examination, that's going to pretty much give you your diagnosis 90% of the time. The special tests and imaging and stuff is just the icing on the cake. If you do a good history and you ask all the right questions, but you also have to have that based on a basis of understanding the anatomy and knowing how to, as the patient's telling you the history, you're going to say, okay, well then that sounds like it's this because I know that if they do this mechanism, it's going to pull on this tissue or this is going to get injured. So the history is most of it, and then the exam is another big part, but the history is actually the biggest part of it. Okay. Okay, so then, you know, foot examination, observation, you're looking for different noticeable deformities of the toes, nails, skin. So, I don't know if this is exactly what's in the PowerPoint, but it's in your notes here, so we're on page 169. You know, you're looking for corns and calluses, hammer toes, mallet toes, different deformities of the toes. It's like with the hands. There's a lot of things that you can observe with the hands, the same thing with the feet. Edema and ecchymosis, their foot stance or their posture, and the shoe wear pattern. Like we said before, remember the normal wear of the heel is the posterolateral, because you strike on the posterolateral heel. That's where you're going to see what the normal wear and tear is. If there's anything other than that, then that's going to be abnormal. So active functional assessment, that's kind of like when we did before with the quick test, you know, where you're just doing a quick scan of range of motion, just do functional things, heel walk, toe walk, things like that. But then as far as getting into the typical things, like, so what are the movement pairs that we have in the ankle and the foot that we're going to measure? Yeah. And you can measure inversion, eversion, or pronation, supination. but we'll talk about more about that later, but there's different parts of the foot that you can talk about, inversion, eversion, pronation, supination. You can talk about the forefoot versus the rear foot and the subtalar joint. So we'll talk about that in a little bit. But really the only thing you're measuring is actually plantar flexion, dorsiflexion. And then on the toes you can measure flexion, extension. So here's the details of the ankle range of motion. So basically with ankle range of motion, you're going to use typically it's going to be easier with a goniometer in this as opposed to an inclinometer. The fixed arm is going to be along the long axis of the lower leg. You can use the fibula as a reference. The fulcrum is going to be, I think, just a little distal to the lateral malleolus. Well, actually, they're centering it over the lateral malleolus. And like we talked about before, is that you can be a little flexible. You can move things around as far as what's going to give you the best measurement. It's more important as far as where you're sighting up on the lateral side of the foot. You know, have a good landmark where you can use this base of the metatarsal. Yeah, so you're using the fifth metatarsal as your landmark here, and then plantar flexion, dorsiflexion. Okay. And then technically you do want to have that in a little bit of supination out like this. So you're tilting the foot a little bit out this way. No, actually this, inversion. You want it invert the foot because it tends to lock it a little bit more. Supination is what locks the foot, supination and inversion, and then eversion or pronation tends to loosen up the foot. So you want to have it in this position technically to get a more accurate reading of plantar flexion dorsiflexion. And then also the range of motion might vary a little bit if it's due to muscle tightness. Whereas, keep in mind that if you have the knee extended like that, you've got the gastroc tightened up. If you have the knee bent like that, then you're relaxing the gastroc a little bit. So if it's an issue of the gastroc on the dorsiflexion, there may be some variation with that. And then I guess on here, I skipped the subtalar joint. And then as far as in the notes, it goes to, you're skipping one, and to match this, you have the toe flexion extension. Are you really going to be doing this very often? I don't think so. But you can understand the concept. Basically, you're using the goniometer and putting the fulcrum over the joint. It's more commonly what you're going to do is just compare one side to the other. All right, so now we're talking about pronation, supination, and that's what occurs at the subtalar joint. So it's underneath the talus. So it's primarily where the talus articulates with the calcaneus, a little bit with the navicular also, and then the cuboid's a little bit involved. But this doesn't move it, basically, but you're talking about this kind of thing moving underneath the talus. So technically what pronation is in the foot is a combination of eversion, abduction, and dorsiflexion. Okay? So if this is the foot, we're talking about eversion, abduction, and dorsiflexion. So it's like this. You're basically, the arch is dropping on the inside. So what's going to happen to the calcaneus is going to be valgus or varus? Valgus, right. So this is basically what happens with pronation. Okay. You kind of get a little bit of internal rotation of the tibia. So again, that's like I said, where it can be a chain where it goes all the way up. So you have this pronation here, internally rotates here, you get a little bit of valgus in the knee. It can affect all the way up into the low back.